Hey, good morning, everyone. I think we'll get started. It is my very distinct pleasure to introduce our speaker today, who will be well known to most of you. Dr. Richard Margolese founded the surgical oncology unit at the Jewish General Hospital several decades ago, later serving as its chief. His impact on oncology, and specifically breast oncology, is the direct Montreal legacy of Dr. Bernie Fisher, who revolutionized clinical research. Like Dr. Fisher, Dr. Margolese did not shy away from science that could have potentially put us surgeons out of business. He pioneered surgical de-escalation with the NSABP B06 trial, which set the surgical standard of care for early stage breast cancer and is taught to surgical trainees across the world to this day. He also led the NSABP B35 trial of adjuvant systemic therapy for DCIS, cheerfully ignoring that old adage of staying in your lane as a surgeon. It is entirely because of him that we have a strong tradition of surgeons leading clinical trials in breast cancer at McGill and, dare I say, cancer clinical trials at McGill. Whereas others may know him for his illustrious academic career, being a member of the executive of the NSABP, serving as the National Director of Canadian Cancer Society, the President of the National Cancer Institute of Canada, or being appointed to the Order of Canada, the JGH Breast Group knows him as its wise beyond measure, deeply pragmatic, and towering founding father. Dr. Margolese, thank you very much for being here today.
Thank you, Ippy, for that kind introduction. What you're looking at is the Roman god Janus, for whom January is named, because he looks back to learn from the past and to the future. And last week, Leanne gave us a glimpse of coming technology and how we educate people. And I'm going to draw on past experience to undermine the importance of science in what we do. Point is that things change, and we want them to change for scientific reasons. Here you see a change that's largely cosmetic, but here's a change that's overwhelmingly different. And the two are different modes of living with change, and we're going to explore that. So the theme of this presentation is how science governs what we have learned and what we do. Everybody knows lumpectomy is appropriate, but does everybody know how and why we got there? One thing I'm going to emphasize is the role of science. The other is the McGill Hospital's involvement in this whole process. Henry Shibata at the Royal Vic and Mike Thurwell at the General were involved almost from the beginning, and were part of this complex journey. You can sum the changes of the past 50 years as from the first half of the 20th century, surgery was the only thing we knew. And we gradually decreased that and went to chemotherapy and are now emphasizing biologics, which, for a better term, I'll use, to show very graphically what we've accomplished. And we're going to try to examine how we accomplished this. The point was that we overturned surgical dogma. When I was a resident, we only knew surgery. Many of you have not seen a radical mastectomy if you're on the young side of our group, but here is one. Whoops. The muscles are gone. You're looking at the ribs and the intercostal space, and when the patient breathes, you see movement. The anterior wall of the axilla is gone, this tissue here, so that you're really looking into the axilla. A terrible deforming operation, but for its time, probably correct. Here's modern, keeps jumping, modern lumpectomy. You can see the radiation changes, which will fade. But this is the story of the two leaders you just saw. The point is, that's the only operation I ever saw. It's the only operation I learned, the only operation that was taught. Nobody conceived, with a couple of minor individuals who stood out, nobody conceived of doing less. And the point was that from getting from there to here wasn't a stepwise transition. It was a reorganization of the entire paradigm of the disease. The story starts here with Halsted at one end and Bernie Fisher at the other, and Halsted's contribution. Note that this says original memoirs. There was not a clinical trial. There was no comparisons. He just thought about this, devised this radical operation, and summarized his results as did everybody else in the first half of the 20th century before clinical trials came along. Nevertheless, Halsted is the father of modern surgery, having devised all the precepts that we now live by. And what was his contribution to this operation? It was a thoughtful operation. People were dealing with an agricultural population. People were not urban. They didn't go to hospitals. And they came in with what we would today call locally advanced disease. So this is, by our standards, inoperable. But in those days, that's what they were dealing with. And Halsted's contribution was to gain control. He believed that cancer spread in an orderly fashion, and it did not spread by hematologic routes. It was a local problem, and local disease would be necessary. There's a direct quote. You've almost all seen this in your history of medicine courses and so on, but he was emphatic that the blood was not involved. And the results of his operation were pretty impressive. He had a local recurrence rate of 6%, whereas everybody else was failing to control the cancer locally. On the other hand, we had a group of cases at Middlesex Hospital in England that were not treated, and you can see very little difference between the long-term outcomes. Nevertheless, there were some long-term cures in the Halsted approach, which gave a little more foundation for the idea of continuing the operation. But basically, survival was not an issue. They didn't look for it. They just figured everyone was going to die anyway. And the gain was in local control. With stage 3 patients, you wouldn't expect much better, but some stage 1 and stage 2 patients started to come along in the first part of the 20th century. But their survival still did not improve. Why? They concluded that was because the operation wasn't radical enough. Nobody thought to challenge the basic thinking that this was a local disease. No one thought that it could be systemic. So they went from radical mastectomy to extended mastectomy, which means they also included the supraclavicular nodes. That didn't help either. So they went to the super radical, which went to the internal mammary nodes, which, as you saw in the picture, were pretty accessible once the muscles were gone. But they still weren't gaining. So we learned that more surgery was not better. What to do? The Halsted paradigm persisted because, as I said, some earlier cancers were presenting and some were cured. Local control was successful, which is what they set out to do. And surgeons had the concept that more surgery was equal to better survival. I remember as a student in a 6-student learning class with none other than Tony Dobell. And in those days, I have to tell those of you who know him, he had a full head of curly hair. That's how long ago this was. But he said, and I remember this from 50, 70 years ago, if you want to cure cancer, you have to be mad at it. So it isn't that people were wrong. It was just the whole surgical paradigm was that. And so people just stayed with it. Halsted's esteemed position at the top of the tower of surgery was important. And the fact that he trained generations of surgeons who carried out the same principles. But by the second half of the 20th century, people were thinking more scientifically. There were some evidence that systemic disease was important. Vera Peters here in Canada collected a bunch of cases that were biopsied, surgery was refused, she gave radiation, and they had pretty good outcomes. In Finland, Mustakallio did some segmentals and published it, but basically these were rejected. They weren't accepted because they weren't enough solid evidence for them. But lab research by Dr. Fisher, who was thinking about this, started to make a change in how we approach this disease. And what he did was he took rats and injected India ink particles into the breast where they were picked up by lymphatics and harvested almost immediately in the venous circulation, establishing the concept of a systemic problem, which contradicted Halstead's thoughtful approach. And this is one example of the kind of disrupting research that Thomas Kuhn referred to. You all learned about him in grade 8 science, that we live under an existing paradigm. New science goes on in terms of observations and experiments. And it's not as if people get fed up with the existing paradigm. It's more that findings and understanding conflict with our existing paradigm. And this disagreement produces a new hypothesis. The paradigm becomes unsettled, and eventually you need to test the new hypothesis. So we have this new era where lab research is telling us that cancer is a systemic disease. The limits of the Halstedian operation were that we weren't curing the cure rates. People were thinking more scientifically. And a clinical trial came along. We weren't the first clinical trial. Sidney Farber treatment of leukemia children and the streptomycin trial. And there were some other solid tumor trials, but it was a tool that we could now exploit. And so Fisher developed the alternate hypothesis that cancer is a systemic disease, that variations on local treatment won't benefit. You can do more or less, but if the disease is metastatic, you're going to have to think of something else. So it brings us to the NSABP trials. And this was a stepwise plan to define the scientific basis for designing breast cancer treatment and challenge the existing reliance on local, regional, extensive control. I joined the NSABP group just about this time as we were opening this trial. And you can see that the first trial was that of lymph node surgery, because everyone was arguing about how many lymph nodes they got. Halstead's mantle passed to Cushman Hagenson at Columbia Presbyterian, who wrote a definitive book, almost a Bible, on breast cancer that we all had to have. And the surgical literature was full of things like, I got 36 lymph nodes in my average axillary dissection, and you only get 28. I'm curing more patients. And literally, this is what people were arguing. So what you see here is the operation was radical mastectomy, the standard, taking out all the breast and all the surrounding tissue. Total mastectomy, which we define total as different from simple, because we wanted to define the operation, which we did in the protocol, where the lymph nodes are not treated at all. And a third group where they got this new arrival of therapeutic radiation oncology, which had been around for decades, but was now being used here in a definitive sense. So we got the trial done very quickly. And the New England Journal accepted it, gave it front article, lead article status, indicating that this was a landmark change. So these are the 10-year results, and we published even the 25-year results, and you can see no difference in the treatment, so that you're not more likely to die if your lymph nodes are not removed. They're not the problem. They're more likely evidence that they're spread, but they're not the cause of the spread. And With this, the surgical world was really shaken because this was the first proof that radical mastectomy was not serving properly. It's not an anatomical problem anymore. So you would think that we would move from radical to lumpectomy very quickly, but it was a very bumpy road. It was difficult for a variety of reasons, political and scientific, social, partly because this was not just a technical change. This was a overwhelming rejection of the science undermining the surgical approach. Some surgeons rejected the outcome of the trial. Um, as Kuhn pointed out, change required a generational shift. So why? Why did it take so long to challenge Halstead in the first place? Why were the results not widely accepted at first? And why was there opposition to moving to the lumpectomy trial? Well, first of all, surgical science was ingrained. The idea was opposite to what we did. The idea was to do more. And so we were causing people to rethink how they thought. Halstead's model was logical. They had locally advanced disease, they had to get local control, and it was anatomically elegant. I can tell you that when you do a radical mastectomy without the muscles, it's a tour de force. When we finished these 3 and 4 hour operations, we were looking at the neurovascular bundle. The entire was an anatomical dissection of the brachial plexus and the blood vessels. Every little bit of fat was removed. It was extensive. And the Halstead operation, while I've said it was unsuccessful, it was successful in achieving local control. And people could point to some cures. Nevertheless, we had to move on, had to fight Halstead's status. He and Osler dominated the first half of the early part of the 20th century at Johns Hopkins. He was an authoritarian image, and trained generations of surgical leaders who, in turn, trained others. So we had this extensive roster of people who thought the same and challenging the radical men, challenging our teachers, our mentors, and so on. Why the BO4 results had a mixed reception? Well, surgeons didn't like to lose their property, a highly technical procedure, and it meant abandoning what they were trained as. They had reputations, so I don't mean individually as much as institutionally. Memorial Sloan Kettering had to say, look, we're the stone for this. We're the experts. Come to us. And they had to continue their status. And the training system, surgicals, senior surgeons controlled training programs, examination boards, even journals. So there was a ingrained foundation that was hard to crack, but we did. There was opposition to instituting a lumpectomy trial, both politically and scientifically. What was happening at this time was chemotherapy was coming along and was being woven or braided to the surgical pathways, and we had to adapt to that. Medical oncologists were having more of a say, which was disturbing and causing turmoil in what we did. But there was an opposition to the trial at CTEP, the Clinical Therapy Evaluation Program. They're the ones that funded these trials. So they kept asking us for more and more revisions in the protocol. The problem is these are two radically different operations as opposed to the first protocol, where it was just a variation on mastectomy. Some surgeons thought it was unethical to randomize to an unproven operation like lumpectomy. The NCI was hesitant. This was a major challenge to what you could say was standard of care. And I remember going down to Washington to see Ted Jacobs, who was the head of CTEP, because they didn't want to hear from Fisher only. They wanted someone else to be able to say, what the foundation was for this trial. So they delayed the implementation of the protocol so long that I have to tell you, in those days, it wasn't like today. We opened this trial without authorization. Dr. Fisher finally said, I'm fed up, I'm opening the trial. And CTEP went along with it and then funded it. You couldn't do that today. So there's the trial. On the left is the trial I showed you before, the radical versus the total. Now you notice the congruency. This is the trial of parenchyma. The breast is being removed in total or lumpectomy with radiation therapy to see if, should lumpectomy be inferior, maybe radiation therapy would make up the difference. So no sooner do we do this when we had to go, no sooner we tell you that axillary dissection wasn't important because it didn't help, we actually had to include it. Because of the advent of chemotherapy, we wanted to know which patients had positive nodes and would require chemotherapy because that was our differentiating point. So we have demonstrated the need for systemic therapy, and we're moving into systemic therapy, but we have to do the axillary dissection. But this was not like the old axillary dissection. This was level 1 and level 2, completely different approach, much less invasive. We had a lot of trouble getting B06 off the ground, not because of CTEP, which was there, but it was a departure. We were not doing a variation of the old operation. We're doing a brand new operation. And recruitment was so slow that we were afraid the protocol would fail. So I sent a questionnaire out to all the surgeons saying, you guys did protocol 4 and we recruited very quickly. You're not putting patients in this protocol, lumpectomy. Why? And the answers I got back were across the board. And at this time, a graduate student in sociology came to our clinic and said, I learned about lumpectomy trial. I wonder if it's a place where I could get a subject for a dissertation. So I gave her the questionnaire, and she was able to come up with this concept of physician therapist versus physician scientist. And she got her PhD and she got it published in New England Journal of all places. The physician therapist says, I must do what's best for my patient in terms of randomizing from mastectomy or lumpectomy. The physician scientist says, I don't know what's best. I got to do the science to find out. So it comes back to the need to do the trial. And we did the trial. So here are the 5-year results that we published. Again, New England Journal took it and gave it a lead article status. Although we had a lot of trouble getting it published, they delayed it the better part of a year. And the edits that came back on the first version were just astonishing. There wasn't a line that didn't have some remark or edit in the manuscript. They held it back until the Italians, with Umberto Veronese, published their version of a lumpectomy trial, which was really a quadrantectomy. But the two were published together. And 5-year, and we got 25-year results, 20-year results. And I've signaled this invasive because we did the same thing for DCIS, but I'm not going to bother showing you that now. One result was the publication in the Journal of Surgery of the results of workshops we held, because lumpectomy in different surgeons' minds was a different operation and we had to standardize it. So Henry Shibata and others held these workshops all over the country, and we put it all together to produce a syllabus of segmental mastectomy. everything in this article is wrong, according to today. We did it then, but we've changed so many things. Not going to show you any more of it. And the outcome was, at 25 years, the same. Mastectomy didn't increase the cure rate. Lumpectomy didn't decrease the cure rate. And by now, other people had started doing the same thing, and there are actually 7 protocols, and they fit together so well in their survival curves that you can hardly tell the lines apart. But moving on was slow. There was a lot of resistance to accepting this, but eventually long-term survival data matured, and patients began to request the operation, and indeed, some surgeons retired and were replaced by others. But there was a lot of turmoil. California passed a law requiring surgeons to inform patients before recommending mastectomy that they could have a lumpectomy. And surgeons who opposed the idea said, okay, I'm going to inform you. You can have a lumpectomy, but if you do, we'll burn you with radiation, we'll poison you with chemotherapy, and you'll die of breast cancer. That's a verbatim quote from somebody who was on a panel with me in one of the ACS symposia. So we eventually got it published, but we have to look at the biology underlying what we did. That's the theme of this conference, and I'm going to dwell on that a little bit. If you go back to Protocol 4, the radical mastectomy trial, one thing we learned was that the radical mastectomy patients were clinically evaluated and found to be node negative. In other words, we didn't have ultrasound, so we just did a clinical evaluation. The surgeon thought they were node negative. They went into this trial. But what we learned from the pathology is that 39% of these people had positive nodes. If you followed these patients, you have to assume that total mastectomy patients, since they were randomized from the same pool, also had 39% positive nodes. But over 25 years, only 19% of them ever showed up with cancer. So that changes the paradigm even more, the concept even more. And local recurrence is the mirror image of this. So we have this study of ipsilateral breast tumor recurrence after lumpectomy to show that even local recurrence is not a problem in terms of survival of the patients. This chart is the other way around. This is freedom from recurrence instead of incidence of recurrence. So the mastectomy group has 100% freedom from recurrence, and maybe there's 1 or 2. The lumpectomy and radiation group, the second line here, has a 9 or 10% recurrence rate and a 39% recurrence rate in the group that was not irradiated. But look what happens to distant disease-free survival. It's all the same. It doesn't matter whether you were at risk for local recurrence or not. And you may think that this slide, this graph, and this line look alike. So I'm going to combine all of these lines into one slide and see that they do correspond. So this means that lumpectomy and failure local recurrence does not lead to distant disease. Rather, bad tumors have distant disease and local recurrence, and they're signaling us with the local recurrence that there's also distant disease. So again, shaking the foundation by looking scientifically at the issues. In another way of looking at this is, if there's no difference in overall survival from different surgical approaches, what does? And the answer is systemic therapy. And as I've said, systemic therapy was coming along at the same time on another track, and the tracks were converging. If this is a systemic disease, as we've been proving, then you need a systemic treatment. So you're seeing the confluence of adjuvant chemotherapy with what we were doing. So now we have two strategies. We still need local control. That's important. And surgery, no matter how much you do, more or less, and radiotherapy are part of that. But in Long Island, this medical oncologist named Dan Martin came up with the concept that if there are micrometastases, maybe they can be managed with chemotherapy in a way that chemotherapy doesn't succeed presently. I did animal experiments with rats where those animals that got chemotherapy following surgery did better than those that waited until the tumor recurred and then gave them the treatment. So that gives us a second strategy of systemic therapy, whether it's chemo or hormones as we went along. And that gives us a new way of looking at the process of cancer. This is the diathesis from inception until someone may die of cancer. They go through early, localized, late, and the clinical pattern was always intervention at some point here and hoping to get the people before it was too late. When mammography came along, because it wasn't a tool that we could use at the beginning of all this, we could shift this to the left and maybe save some lives. But the reality is, this whole slide is now in this little box over here on the right to show you that the time before clinical cancer is much longer. As a matter of fact, it should look more like this or even more squeezed. And Vince Collins, who was an oncologist in the 1950s, it wasn't such a word then, but he was treating lung cancer. By looking at metastatic nodules in the lungs over time in people who weren't treated for them, he came up with a growth curve that shows that most of a cancer's life is spent invisible and that it rapidly increases in size. The time it takes to go from 200 cells to 400 cells in terms of doubling is the same time it takes to go from 200 million cells to 400 million cells. Now, it's not all that neat and mathematical. Cells die, they don't have blood supply and nutrition. So you can attenuate this curve a little bit. But you can see that by the time you can find a cancer in terms of 3-4 millimeter size, it's already had plenty of time to spread. And most cancers, if they are capable of spreading genetically, will have done that by now. Halsted didn't realize this, and the operation he designed didn't take this into account. But what we learned is that all these operations, either more extensive or less extensive, didn't change much until chemotherapy came along. And so we have to take a look at that. Contemporary chemotherapy in the 1970s was for metastatic disease, and it wasn't that effective. It just added a few months of survival to some patients. But with the concept of micrometastases, which at first were thought to be two dislodged cells by the surgeon, but we see that's wrong. We really see that those have been there long before the surgery took place. Gives us a whole new track of how to treat patients. So the first adjuvant chemotherapy trial was LPAM, which was phenylalanine mustard versus placebo. And there was a difference, but this is a very deceptive slide. First of all, notice it's truncated so that the spread is not as good as it looks. And secondly, this is a subset of patients, which you're not allowed to do. This is premenopausal patients with positive lymph nodes. But there was a difference. But with this comes an awful lot of drama. Um, we never got to the point with this trial where we could show a survival difference because the trial was halted. President Nixon had brought in the National Cancer Act in first term, and it was 3 years later, and it was up for renewal. And he wanted ammunition for Congress to renew the act and the funding. So they called all of the groups. By now, there were many groups doing adjuvant therapy. Acute leukemia group B. There were two acute leukemia groups, Farber's group in Boston and St. Jude's in Children's. That was called A, and the adults was called B. And they said, oh, look at this interesting result in adjuvant chemotherapy. So we're going to now be CALGB, cancer and leukemia group B. And even we, the NS National Surgical Breast Project, added the A for the adjuvant therapy. The GI tumor study group was formed. Antoine Lutfi at the Vic headed that up. And the lung cancer study group was active. But the NCI called together all these groups to a symposium in Bethesda to present their material. Our study wasn't mature, and we weren't going to present data. And so I remember distinctly Bernie Fisher and Carol Redmond, our statistician, and I were escorted out the back door of the auditorium up a grassy slope to the director's office, it was then Frank Rauscher, and he told us the NCI, we didn't know that the results were promising because it was still blinded to us. We still hadn't reached a overall value for stopping. But Rauscher told us that the word from the administration was present your data. Congress needs to see it. So all of the groups had to present their data, and disruption of good science by politics is apparent, but we had to live with it. Nevertheless, it did go on to present, to cause some turmoil, but also some optimism. Looks like we were able to cure cancers that we couldn't cure before. So with this proliferation of groups, we had all a bunch of new questions, and we embarked on this stepwise program of a single drug versus placebo that you see here, then two drugs, then three drugs, then the addition of tamoxifen because Elwood Jensen had just discovered the estrogen receptor in the 1970s. And although they thought it would be a good birth control pill, it wasn't. But somebody gave it to some rats with cancer and it had a good effect. So we did a trial with tamoxifen, and that set us off into a whole new ladder of trials using tamoxifen. This was an intensification of dose, and this is pre-op chemo, which we now call neoadjuvant therapy. And over this period of time, there were incremental improvements. Each of these trials is here compared to its control group. It's not very exciting, but there's gradual improvement. What's exciting is when you turn to the addition of biologics. This represents the addition of a genetic or growth factor trial, which you see here. Um, this is standard ACNT, adricyclo and taxane. And people who express the HER2 growth factor, human epidermoid cancer receptor, um, discovered in the 1990s, had a very bad prognosis, even with chemotherapy. But because of the development of Herceptin, an antibody to this protein, they had a very good overall survival. So you're looking at, I wouldn't say the first demonstration, because tamoxifen is also a biologic in a sense, but significant cures. People are being cured long term with this approach. There's yet another benefit or derivative. The thing that everybody uses every day called Oncotype was developed from our studies. Our pathologist, Soon Paik from Korea, took the results of three of our trials where we had a control and a treatment group, and he looked at a bunch of genes that were known to be active in proliferation, others in invasion, the HER2 group, the estrogen group, and the reference genes. And he came up with a mathematical expression of risk, which we've changed since then. This is the original one. But you could now select people for chemotherapy with increased expectation that you would be doing good and not treating a lot of people who don't need it. So the idea that all patients in a category would be given chemo and have maybe a 30% chance of benefit gave way to the idea that it would be more effective if you selected your patients according to their risk, because baseline treatment would be just too ineffective. So once we have this concept of the long phase of cancer or precancer compared to the very short clinical phase, we have to move to chemotherapy, from chemotherapy to prevention therapy. We had done a trial, which I haven't yet shown you, called B14, which was lumpectomy versus tamoxifen. People got lumpectomy radiation. And there was a benefit, 35% decrease in treatment failures. But the other thing we didn't expect to see was effect on the opposite breast. And this was confirmed by other people in other countries doing tamoxifen study, showing that by 5 years, there was a significant suppression of the expected rate of new cancers in the opposite breast. So the suggestion was that we could prevent cancer. So off we went to do another clinical trial, very much like the tamoxifen trial for breast cancer. In this case, it was for people who didn't have breast cancer but had high risk. 13,000 patients were recruited and received tamoxifen or placebo for 5 years. The outcome is positive in the sense that the rate of cancer was cut in half from 43 to 22. But if you look at the number of events, it's very small. And so we have a great big pool of patients. Even placebo group didn't have a high rate of cancer, even though we thought they were high-risk patients. So what do we do? Well, we have a proof of principle that we can do something, but the absolute benefit leaves us a little bit short of making this a widely accepted treatment. The issue of giving a medication to someone who's good health was met with a lot of resistance. These people don't have cancer, they have a risk for cancer. And why expose them to the side effects of tamoxifen, which weren't great, but weren't zero? So the uptake of the idea of prevention with tamoxifen was pretty much muted, was mild. The other side of the coin is the side effect of not taking prevention is that some people will have cancer that might have been prevented. So we need tools for better selection, and those, are coming along. But the point is, we've moved from cancer as a surgical problem to considering that cancer is now a disorder of growth, and that surgery, whether radical or conservative, is a partial solution. It does reduce the tumor volume and gains local control, but there's no question that we have to think more biologically, so that what I've been developing with you is the de-emphasis of surgery and node dissection. We see that today in sentinel node. We're still doing trials with variations on how much node surgery and who needs node surgery, and radiation with partial breast irradiation and so on. But these are all experiments within the paradigm. They fit into Kuhn's definition of new science within the paradigm because they're still fit with what we had emphasized with the big surgical trials. We're into pre-op chemotherapy and the possibility of complete response, meaning maybe we don't have to even operate at all, so that surgery is becoming the adjuvant treatment for breast cancer. But this is still ordinary science in terms of Kuhn's approach. The basis for this is the science that we've been doing, and I hope I've been able in this short time to give you the view of the importance of science to underscore the foundation for the thinking that we do. So we're back to the original concept where we moved from surgery as the only treatment. And I emphasize that was the only treatment that I saw as a resident for the whole 7 years to a present condition where surgery's kind of got a role, but it's not that important. But the biologics of cancer are important. And the move from Halsted personal approach to science-based thinking is illustrated by these clinical trials. So, summary, cancer is a disorder of growth. The earlier treatments were primitive. We now have a much more sophisticated view. Prevention will have to be incorporated into our strategies. I hope that this personalized review has been interesting to you. I didn't go into the new uh, molecules, the ribociclib and PDF1 and so on, because you guys know more about that than I do, and we're still in the evolving part of that, and they are part of scientific investigation. But I've shown how we move from the anatomic view of cancer to the biologic view. Randomized clinical trials established the change and led the way for the more modern studies of the ones like the biologics that we're now talking about. And I see I've got a couple of minutes left, so if anybody wants to ask questions, I thank you for your attention and I'm willing to see what your questions are.
Well, thank you very much, Dr. Margolese, for that remarkable, truly remarkable perspective on how breast cancer care has evolved over the last few decades. I do think your career has spanned and directly led to some of the most transformative change that we've seen in surgical oncology, in modern surgical oncology. I see a hand. Maybe I can start the discussion off and then I'll let Dr. Chevenkov ask his question. So you spoke about the resistance you faced, especially with the NSABP trials. When you look back, what sources of resistance surprised you the most that you would not have expected, whether it be from the clinical world or the patients or policymakers?
Well, I think the resistance was twofold. One was the lofty status of Halsted as a teacher, as a trainer, and as I said, all of the important people in surgical departments in universities were Halsted trainee derivatives. Either he trained them or he trained the people who trained them. So they had this concept. I remember Dr. Eddie Taba, Roger's father, was a delightful mentor for me over the years because he was a cancer specialist. He was really the only one identified. And when I talked to him about this, during those years trying to get the BO6 off the ground, I went around to dozens and dozens of universities and grand rounds and symposia. So did Norm Marwick and Henry Shibata to try and get this idea across that we could at least look at the science and do the experiment before we had rooted our conclusion. And Eddie said to me, my training and my experience make it very difficult for me to move away from the classical treatment. He said, but I encourage you to do it. You're on the right track. So it shows you how conflicted people can be if they do something that's been instilled into them and how difficult it is to adapt.
Dr. Chevenkov?
It's wonderful to hear your presentation, Dr. Margolese. Um, I benefited from being a resident with you and Dr. Norm Beliveau, and at the early days of lumpectomies that you guys were doing and being nice to your women patients compared to all the rest of the surgeons I was exposed to. And I almost went into the field. I became a transplant surgeon, though, and a student of immunology. And it's great that the paradigm shifted to less surgery and more thoughtful, prospective randomized trials. I think that's the future. But maybe it's time for the paradigm in cancer to shift again. I'm at the forefront, along with Jonathan Cools, in looking at how the myeloid compartment shapes response to therapy and metastasis. What kills patients is not the primary cancer, and rightfully, you have shown that control of the local disease does not alter outcomes. But I'm going to go on a limb and suggest that cancer-centric, so-called precision medicine, looking after the latest mutations and etc., is also maybe not the answer. So, what are your thoughts on, for example, using simple stuff to look at if the cancer does not induce a myeloid response, it cannot really metastasize. So the way cancer metastasizes, it prepares niches for the cancer cells. Otherwise, they are killed. They can't survive. And those niches are prepared by neutrophils and macrophages that are induced by the cancer itself, by the bone marrow. And so if it cannot induce a high neutrophil to lymphocyte ratio, it actually is very easy to treat. But the more you treat the cancer, the more you induce stem cells, the more you induce pyroptosis and apoptosis and these little particles, the more it induces the bone marrow, the more it becomes resistant to even immunotherapy. So what's your thought on that? And we have now taken the approach with Jonathan. I've actually talked to Mark Bazik, and we have actually a drug targeting ROR gamma. And ROR gamma is a nuclear receptor that actually is prevalent in most cancers and is part of this emergency granulopoiesis that cancer induces and triggers this response of the myeloid compartment. What's your thought on that?
You can't ask me for too much thought on that because I'm at the end of my career. I've helped move us from anatomic to biologic, and you're talking about these biologic changes, which are part of the challenge of what the younger generation of oncologists are inheriting. There's an extensive literature on the tumor environment. There's extensive literature on metastasis as a phenomenon. So, as I said in my conclusion, this can be up to other people. I'm passing the torch.
Certainly a lot more paradigms to shift. Dr. Stein, I see your hand up.
Well, there's a lot more
Yeah,
to do within the paradigm that took us away from anatomic to biologic concept of cancer. Cancer is a disorder of genes. It's a disorder of growth. So we now have tools to intervene in those areas. And
It's also a disorder of inflammation. That's what I'm trying to get to. I think chronic inflammation is the basis of many pathologies,
yeah,
and most cancers are not actually genetic. Most cancers are a way of life, which induces chronic inflammation, just like other diseases.
genetic.
What I'm treating, which is diabetically induced chronic renal failure with renal transplant. But we're not treating the diabetes. We're not treating the chronic inflammation. That's what I'm trying to get to.
Jean,
Dr. Cherenkov, I have an eye on the time. We have 4 minutes and a couple of hands, so maybe I can let Dr. Stein ask a question.
it was just a comment you had asked, Dr. Margolese, what was some of the impediments. I went through and I lived through these changes and seeing surgeons doing going on protocol and not changing within our own institution here at McGill. And I remember when I came on staff, there was a person who was the head of department who had certain thoughts And Richard and I had a very nice conversation when I was very new on staff about protocols. And I think that the difficulty and I think the importance is getting people to register all their patients on a protocol, and that way the science moves along a hell of a lot faster. And I think that there was a lot of difficulty during that time of getting people for breast and then for colon to getting them on. People seem to have excuses. Oh no, this patient can't go on because of this or because of that. And I think that was a very big impediment and a very big thing. And Richard was masterful in getting people on board and understanding the concept of the clinical trials.
Thank you.
Dr. Wong.
Yeah, Richard, I'm going to ask my questions a little bit later when I see you in tumor board, but I just wanted to say, as I'm sure you know, I could hear you give this lecture, I think 100 times and still learn something new from your experience, from the history and the story, like learning about the science to the sociology, the legal rulings in California to the political influence, how patients drove a lot of these changes and how there was so much physician equipoise and or resistance. I just want to congratulate you. As you know, we all understand what a giant you are, not just because you're very tall, but also because of your illustrious career. And I think if any of us had a mere fraction of the transformative career that you have had and how many women's breasts you've saved over the last several decades, I think we would all be very happy. So thank you so much for this incredible grand rounds and for everything you've done.
Thank you, Stephanie.
Dr. Basic has a question comment. He's having trouble with the hand raising. Here you go.
Thank you, Richard, for this masterly talk, as always. And I second what Stephanie just said. It's really been a trailblazing career and really opened new possibilities. I just want to underline two things. One, this opposition that you experienced and you remember talking about Vincent DeVita going to the NSA, all these things. It's still something very much alive in science. Science is a strange bird because we're creatures of habit, and I guess certain concepts get ingrained, and challenging them is always difficult and will always be difficult. And so it's quite amazing that you and your team were able to get this far and analyze this really in a very scientific way, which I really appreciate. But we had a paper just accepted in doing a different circulating tumor DNA method, which challenges the paradigm of what people are in. And the reviewers just couldn't accept it because they just didn't believe it, even though the results were what the results were. And so this is something that's still very, very much present and will always be present. And so it takes a lot of courage to continue, again, based on very strong scientific data. The preclinical data that Bernie Fisher had was so compelling, and the clinical data went to really confirm it. So that's really, really wonderful. And of course, as you know, we're now heading into the removal of surgery, perhaps altogether, the removal of radiation, the logical conclusion of all the steps that you've taken. And we'll see where that takes us. It's still also very fraught with all kinds of obstacles. So thank you very much. In the end,
The reason I kept emphasizing the word science is because, as you just pointed out, people develop ownership of a point of view, especially in their own research.
Yeah.
It's very hard to keep people moving, whether they're moving within the paradigm or whether it's a paradigm shift. So we have to keep working at it. Good.
Once again, thank you very much, Dr. Margolese. We're right on time. I will close this session. Thanks, everyone.